So, back to that question about why they are so underutilized, I guess we've raised some of the issues. Some of it is maybe the hassle that clinicians might feel. There's perhaps some patient resistance, and you said that if a patient is adamantly refusing medication, they're probably not going to get the injections either. But I think for the average patient, it's more of an issue in the way the clinical team is communicating this, and the ambivalence perhaps that people have. And we've talked about some of the, I guess, concerns about how medications are necessary or not, and are we overusing them. I think once the clinical team gets to the point where they say, this patient should be on medication, then it should be relatively straightforward to say, well, why not use a long-acting injectable formulation? I think this is still this fear we're being too paternalistic or too invasive if we give someone an injection. But
there's actually something that's even more, I don't know, potentially problematic than that. People that are candidates for LAIs are usually SMI patients, serious mental illness. And serious mental illness are usually Medicaid or sort of lower SES, and they're getting treated in clinics, and the clinics are often run by non-physicians. And there's maybe sort of a discipline or ideological sort of orientation that is not facilitating optimal usage of these more complicated treatments.
I do think, but I think that all may be true. I think we also want, we are trying to respect patient preference though. So I think docs shouldn't be the barrier. Docs should recommend it, make sure there are no structural problems we could do away with, ideally do away with health system issues. But, if patients really have a preference for oral medications, it's kind of hard to override that.
But if they want oral medications, they have to take them, right?
Well, I think the challenge is no one wants an injection, right? I mean, if you say to somebody, how about we give you injections instead of pills? Most people are going to say, no, I don't want that. So they have to understand what the issues are. And I think my response is, look, we've treated many, many people like you. And what we find is that anybody with a chronic illness, whether it's diabetes or hypertension or schizophrenia, they have trouble taking their medicine, for lots of different reasons. Why should we take a chance on that? Why should we take a chance on you getting sick again, ending up back in the hospital, losing all the gains that you've worked so hard to achieve? So let's do something that's going to really facilitate that. And
how often do you think that docs have that kind of conversation?
I think that's where we fall short.
They have
that
to
we
be
need
taught that way early.
We need to teach doctors how to have that conversation.
Absolutely.
Right. I mean, to use their experience and knowledge and their powers of persuasion. Yeah. I mean, that's what you're talking about.
And it's part of the therapeutic alliance. I mean, some doctors say, well, it's going to interfere with the therapeutic alliance if I recommend an injection, because that means I don't trust you. But I think what we're trying to capitalize on all of our past experience, on all of the data that enable us to try to help that patient avoid what some other people have experienced.
Right, it's a superior form in which the medication can be provided. Let me ask you a question though, John. Speaking of the LAI, second generation drugs, so Scott did, really the, sort of pioneering comparative effectiveness of first and second generation long-acting injectable medicines. It would be good, so Relprev is, the olanzapine is kind of out of the picture just because of the, what is it called, post-injection delirium sedation or something like that?
That's right, yeah, that's it.
So it's got
syndrome.
A bad mark against it.
It's a rare effect, but it does happen, and it means that patients need to be observed for a couple of hours after the injection. But for some people, it's still a very valuable drug.
Is it being used?
It is
being used.
It is valuable, but it's being avoided like the plague, because of the fact that this rare effect, just like clozapine, it's used as in ground cytosis, which is manageable, is used as an excuse to not use clozapine. But Invega Sustenna, or Invega, palperidone palmitate, or whatever, pamoate, or whatever version of it you want to use, versus aripiprazole. That would be an interesting study to see.
Well, there have been some studies, but I think the question again is making a personalized decision for each patient and trying to decide what's the best medicine, and we do that with oral medicines all the time.
Wouldn't
right?
it be nice to have data to base that personal decision on?
Sure.
Do you have any predictions how that would pan out?
I think the studies comparing paliperidone or risperidone with aripiprazole have shown that they're pretty similar, except in terms of side effects. So people worry sometimes that one drug is more efficacious than another, but I think in general, against positive symptoms, the antipsychotic drugs have been pretty similar in their effects, I mean, except for clozapine.
Well, that's what Scott's study showed with Vegas. So if the difference between Invega Sustenna and aripiprazole in whatever formulation it's compared to, or both, then the question is, what are the side effect differences that would emerge from that, assuming the efficacy would be comparable?
Yeah, and which patients are vulnerable to which specific side effects, and someday hopefully we'll be better able to predict that.
And who will benefit from 2 weeks, 4 weeks,
Right.
6 weeks, or whatever the upper limit is now.
Right, no, absolutely.